ISTDP is a form of therapy that was invented by Habib Davanloo through his research in Montreal General Hospital in the 1960s, 1970s, where he studied a group of outpatients. And he was unhappy with the results of psychoanalysis as a form of therapy and psychoanalytic psychotherapy. And his idea was, in short, if he could create an intrapsychic crisis in the patient over the ways in which they resist getting well, he felt he could make accelerated improvement in patients' adaptation to life, decrease their symptoms, and help them undo self-destructive patterns of personality in their relationships and in their careers. He had gotten that idea from doing trauma work with a very famous researcher named Lindemann, and they studied patients from the Coconut Grove disaster, and in acute crisis he noted that he could get to the unconscious mind more quickly than he could in traditional talk therapies with patients. That's where he got the idea of creating an internalized crisis to, quote-unquote, unlock the unconscious. So I had become a student of Dr. Davanloo and studied with him in what he called core training, and in so doing developed the skills in his technique, which really put the process of interpretation on the back burners. And the whole focus of therapy was helping the patient experience their real feelings about the present and the past in the here and now. And this form of therapy was studied and found to be remarkably effective, equally effective to any other form of therapy that's ever been monitored or measured as far as outcome is concerned. It was all based in Davanloo's theory that ruptured attachment bonds lead to a complex of feelings, rage, guilt, grief, love, that are buried in the subconscious and have to be processed for the patient to set themselves free. I began studying attachment theory when I was medical director of the Lifespan Learning Institute with my colleague Marion Solomon, and we did a series of workshops and lectures with all of the great attachment theorists that were living and practicing in the United States today. Mary Main, Eric Hesse, Ed Tronick, Dan Siegel, Alan Shore. We had an amazing, amazing group of people, and I was pretty much immersed in attachment theory. And then the piece de resistance was being able to go to University College London and attend Mary Main's adult attachment interview. And I started getting intrigued by the relationship between emotional experiencing, early childhood attachment, and development of linguistic structures. So I modified Davanloo's original technique according to some of the principles of attachment. And the technique has now developed into the idea that people with quote-unquote pathological superegos are repeating and internalizing the original attachment trauma of their childhood and are stuck at that level of psychological development. We attempt to deconstruct what I call the pathological superego, which is the internal representation or the working model of attachment, and replace that insecure model with what we call the healthy superego, the loving superego, which realistically praises, gives encouragement, doesn't cause shame, and all of those kinds of factors. So we change what I call an insecure attachment style of mind or state of mind to a secure or earned secure state of mind. I did a bit of research on that and showed that I was able to accurately identify by videotape the patient's attachment styles, as well as the adult attachment interview did. So that further encouraged me that I was on the right track. Like all things, this is a work in progress. The ideas are fluid and evolving, and it's a very, very exciting way to approach psychotherapy. And furthermore, it's even just as exciting, if not more so, of training psychotherapists and how to administer this technique. Once you get a taste of helping someone change their internal working model of attachment, it's very hard to do therapy any other way. We start off the interview with inquiry into the nature of the problem and make a very concerted effort to take an inventory of what the patient's goals are. What's going right in their life, which we don't have to do very much about, and what's not going so right in their life, and what symptoms are they suffering from: anxiety, depression, phobias, obsessions, compulsions, etc. And what personality patterns are they having? Do they grab defeat from the jaws of victory? Are they having difficulty regulating their own emotions in relationships? A whole host of other potential relational problems. So inquiry is a huge method where we ask those very, very important and salient questions. Once that's established, then we move forward into a series of interventions. Most common would be pressure towards experience. Another one would be challenge, which means blocking the old patterns of defense mechanism that the patient is using and insisting that they not use them during the therapy session. Another one would be confrontation, identification, clarification. Another one would be head-on collision, meaning that the patient is confronted with the lack of omnipotence in the therapist, that their recovery is going to take a lot of hard work on their part as well as on the therapist's part. And we use, as does Davenlu, the development of the intrapsychic crisis to move the patient through a phase of resistance. And then last but not least, we do a certain degree of cognitive recap where we summarize according to what's called the two triangles: the triangle of persons and the triangle of conflict. And all interpretation is structured along those two triangles. Very much so. As I mentioned, the style of linguistic expression reflects the attachment style. So occasionally the psychotherapist will model for the patient using appropriate language in being able to express one's emotions to the abusive parent or the neglecting parent or the offending sibling, whomever it is, where the highest charged emotional relationship is that's causing the patient anxiety. The therapist will use that sort of, I call it psychodrama technique of doubling, where you model for the patient the healthy ego. The other techniques are deep attention to an accurate observing ego and deep attention to what we call the attentive ego, intervening on the patient's behalf. This is extremely important with neglect paradigms, people who remain languishing in anxiety and don't have any tools to intervene in a constructive way to regulate their anxiety. These are the most, I would say, the most glaring technical differences. There's also a theoretical difference that we put a great deal of emphasis in what we call separating the constructive ego part of the patient, the part of the patient that wants to get well, from being under the thumb or the domination of the pathological superego. We spend a lot more time doing that work than preliminary work than does the traditional ISTDP therapist. The attentive ego means, are you a caring, responsive parent, internalized parent who intervenes when the child is showing signals of psychological distress and being overwhelmed, as opposed to being dismissive, minimizing, or ambivalent about it and responding to the child with aggression. There's been an avid study group in the United Kingdom that was catalyzed by one of the founders of this technique, in addition to Dr. Davanlu, David Malin from the Tavistock Clinic. And he's a real pioneer of the science of psychotherapy in Great Britain. And he brought this approach to the UK. And there's now ISTDP UK, which is run by Alexandra Knowles and Sharon Lewis, and they are doing a phenomenal job of structuring a curriculum that makes this difficult technique as easily learned as is possible. They've been stellar at refining the educational process, and I think 8 core groups have been formed, and 7 are in the process of being graduated as we speak. No, I don't think there is.